Good morning, everybody, and thank you as always for joining us. Hope everybody's having a great holiday season. We're just giving it a moment for everybody to join in the webinar. We have a very, very special presentation today that we're very excited about. But before that, we have a couple purposely brief updates for this week's presentation to save time. We'll turn over to Dr. Pinsky to talk about updates briefly on variants.
Thank you, Errol. Good morning, everyone. With all the intense interest in Omicron, I'll give a brief update on what's new in the last week on this variant. Of course, Omicron has a very large number of spike mutations. The news with the mutations is that there are now two proposed sublineages, the original BA1 and a second one, BA2. Importantly, BA2 lacks these mutations, so would not show up in this S gene target failure that many labs are using to screen for Omicron. So that's something to keep in mind going forward. For the Omicron characteristics, it's likely that there's increased transmissibility. We know it's been identified globally. There's cases in numerous US states, including California, with 5 additional cases identified in the Bay Area, at least 5 additional cases identified in the Bay Area in Alameda County. And many of these cases are individuals without international travel. There's a lot more data this week about susceptibility to antibodies and potential decreased effectiveness of vaccination. Data came out from GSK and Vir suggesting that sotrovimab likely does retain in vitro activity against the individual mutations found in Omicron, and so will likely still be effective against this variant. There's also neutralization activity that's been reported both from South Africa and from the Karolinska Institute here from the South Africa group, showing relatively substantial decrease in neutralization against the Omicron variant. However, you can see that those folks that were infected and then were vaccinated with Pfizer have still neutralized the virus. So it's thought that the vaccines will still at least be somewhat effective against this variant. And that was reported today in the New York Times from both Pfizer and Moderna. Their data has not yet been published, but it suggests that there is still neutralization activity despite the presence of these large numbers of mutations. And that's shown also here with pseudovirus neutralization from the Karolinska group with less fold reduction in neutralization. And this is consistent with their use of a pseudovirus as opposed to a viral isolate that's been shown elsewhere. There's also some data from South Africa indicating substantial population level evidence for evasion of immunity from prior infections. So these mutations are associated with breakthrough infections, as we have seen. For other characteristics, the severity remains uncertain. Reports, though, suggest that disease throughout the world has been relatively mild to moderate. Although we do know that increases in hospitalization typically lag a bit from the initial diagnosis of cases. And then there, again, no known impact on diagnostic testing. Either the assays used at Stanford or Color target different regions of the genome, but we'll have to look at this new lineage just to make sure. And of course, these assays will require to be tested against actual virus. And then there's no known impact on rapid antigen tests, which typically target the nucleocapsid antigen. And just remember that rapid antigen tests are relatively insensitive compared to the molecular diagnostics. And so if you have a negative with a rapid antigen test, that does not rule out infection with SARS-CoV-2. And then at Stanford, so no cases identified yet. Everything is still Delta and Delta sublineages, as you can see in these familiar graphs. We are doing mutation-specific PCR to identify Delta, and then everything else gets sequenced. So we should be able to identify any potential Omicron variants very rapidly. So thank you. That's my update for this morning, and happy to take any questions in the Q&A.
As always, again, Dr. Pinsky, thank you so much. And we'll continue to update the community every week as this progresses. So next, I'd like to just say we have a special, very special guest today. We're really excited for that. Briefly next week, we have Dr. Pardis Sabeti, who will be joining us from Harvard with the lecture Sentinel Preempting and Responding to Pandemics in the Genomic and Information Age. This is our American lecture, and we'll be hosting that next week, so I hope to see you then. But coming to this week, I'm going to turn it over now to Dr. Dzau Wu, who's the director of our Cardiovascular Institute for Stanford, as many of you know, and he's going to be introducing our, of course, our honorable speaker today, as well as talking about the Victor Dzau Distinguished Lecture that we're having today. So Dr. Wu, I'll turn it over to you now.
So thank you, Errol. So hello, everyone. It's really my great pleasure to welcome all of you to the inaugural Victor Dzau Distinguished Lecture in Cardiovascular Medicine today. The Cardiovascular Institute is also sincerely grateful for the support of our donor, Ms. Lois de Liga, who is a passionate champion and supporter for advancing cardiovascular research. Now, we're honoring Dr. Dzau today because he is truly an internationally acclaimed leader and a physician scientist who has made a significant impact through his seminal research in cardiovascular medicine and genetics. Just as an example, his research laid the foundation for the development of a new class of life-saving drugs called ACE inhibitors that are now used globally to treat hypertension and heart failure. Dr. Dzau has also pioneered research in stem cells and gene therapy and was the first to introduce DNA decoy molecules to inhibit intimal hyperplasia in patients. Dr. Dzau is currently the president of the U.S. National Academy of Medicine, vice chair of the U.S. National Research Council, and is chancellor emeritus at Duke University. Before that, Dr. Dzau was chair of the Department of Medicine at Brigham and Women's Hospital. But of course, we like to claim that his amazing career was all made possible because he started out as a chief of cardiology at Stanford from 1990 to 1996, followed by becoming the chair of the Department of Medicine. During his leadership at Stanford, Dr. Dzau significantly expanded cardiology division's research by recruiting top talent, top-notch young physician scientists. And among them was the young Dr. Gary Gibbons, who is currently the director of the National Heart, Lung, and Blood Institute. Among Dr. Dzau's many honors and recognitions, which I will just name a few because of time, are the American Heart Association Research Achievement Award, the Max Dahlbrick Medal from Germany, the Ellis Island Medal of Honor, and the Henry Fraser International Prize. In 2019, Dr. Dzau was named an honorary citizen of Singapore, the highest level of honor bestowed to a foreign citizen conferred by the president of Singapore. He has also been elected to multiple national academies in the US, UK, Japan, China, Taiwan, and other countries. On a personal note, I have known Victor for the past 15 years. I'm truly grateful to have Victor as a friend and as a mentor. And I have always sought advice from Victor before making any important career decisions. And for that reason, I want to thank our donor, Ms. Lois de Liga, again, to help us set up the Victor Dzau Distinguished Lecture in Cardiovascular Medicine, and to have Dr. Eugene Braunwald as our inaugural speaker. Now I'm going to pass the podium over to Victor. Victor?
Thank you very much, Joe, and to Dr. Bob Harrington. I'm extremely honored by the establishment of this lectureship at Stanford, an institution I so admire and respect. And I'm grateful to you, Joe, your friendship and your effort in conceiving this idea, and then made it a reality. And also a special thanks to donor, Ms. Lois de Liga, whose generous gift endowed this lectureship. I'm touched by the gracious acceptance of Dr. Braunwald to be the inaugural lecturer, and I'm delighted to see many of my friends and colleagues attending this lecture today, and certainly glad to see the presence of many young faculty and trainees. You know, Stanford occupies a very special place in my heart as I spent formidable and important years of my academic career, where I learned about leadership, innovation, principles, values. And although it was a short 6 years, the impact on me has been lifelong, which is why this lectureship is especially meaningful. I do want to express my deepest gratitude to Dr. Eugene Braunwald. I hope he's online to hear my comments. He's my mentor and close friend, who's had a profound influence and personal impact on my life. Gene, you are my esteemed role model of physician, scientist, and leader. and I would not be here where I am today had it not been for your belief in me and your unwavering support and your deep friendship. So thank you, Gene. And thank you, Joe, for your friendship. You have led the Stanford CVI to great heights, establishing as a global leader in cardiovascular research, and your own research is making really important impact in cardiovascular medicine. And to my friend, Bob Harrington, for your excellent leadership of the Department of Medicine. Wonderful to see the growth and energy department under your leadership. So for me, it's wonderful to see two of my friends and mentees thrive at Stanford. You have both exceeded everything I tried to do during my years at Stanford. I'm very proud of both of you. So thank you for this honor. I certainly look forward to hearing Dr. Braunwald's lecture, and I look forward to seeing all of you in person annually in the future. So thank you.
Thank you, Victor. Now it's my great pleasure to introduce Dr. Eugene Braunwald. Dr. Braunwald is the Distinguished Hershey Professor of Medicine at Harvard Medical School, Chair Emeritus of the Department of Medicine, and also the founding chair of the TIMI study group at the Brigham and Women's Hospital. Dr. Braunwald is often called the father of modern cardiology. Among his many scientific discoveries, he was the first to define the pathophysiology of hypertrophic cardiomyopathy and to demonstrate the salvage of ischemic myocardium following coronary occlusion. In recognition of his seminal contributions in cardiovascular medicine, the living Nobel Prize winners in medicine voted Dr. Braunwald as the person who has contributed the most to cardiology in recent years. Dr. Braunwald has received Distinguished Scientist Awards from the American College of Cardiology, American Heart Association, and also European Society of Cardiology. He is the first cardiologist elected to the National Academy of Sciences in the US. He has received honorary Doctor of Science degree from the University of Oxford and also from 23 other distinguished universities. Thank you, Dr. Braunwald, for being so kind and so generous with your time and also accepting our invitation to kick off the Victor Dzau lecture series.
And I just want to mention, we're playing a pre-recorded video by Dr. Braunwald, but Dr. Braunwald is here with us live currently to answer questions right after we play this video, which runs about 30 minutes.
Good morning. It is a distinct honor and a great personal pleasure to deliver this inaugural lecture, which celebrates one of the truly great leaders in cardiovascular medicine, Dr. Victor Dzau. Dr. Dzau is, of course, well known to all in academic medicine now as the president of the United States Academy of Medicine. What was the road that he traveled to achieve this most distinguished position? Well, Victor was born in Shanghai, and here is the future president of the National Academy of Medicine at the age of 4 months. The situation in China during the communist takeover was extremely dangerous, and the Dzau family escaped to Hong Kong, at that time a British colony. Here is a picture of the family and Victor at the age of 7. Here he is now at the age of 11 in Hong Kong. He's in middle school, and to seek the best higher education, at the age of 18, Victor by himself moved to Montreal to attend McGill University, the undergraduate and the medical school. Victor's medical residency was at the Brigham and Women's Hospital, and this photo was cropped from that of our entire house staff, taken in 1975. Long hair among house staff was in fashion at the time. Victor's performance was, of course, spectacular, and after completing his assistant residency, he took 3 years of fellowship in cardiology and returned to the house staff as the chief medical resident. After this, he stayed in the Department of Medicine and rose steadily to associate professor. And he established the first division of vascular biology in the Department of Medicine, which was very successful. Now, in 1990, he received an offer to become chief of cardiology at Stanford, and I urged him to take this important position. However, when he came to my office to say goodbye, I got up from my chair and I asked him to sit in my chair. He was puzzled, but quite comfortable. I told him that in 6 years he would return to this chair, which I had inherited 18 years earlier from my predecessor, the great George Thorne. Of course, I was correct, and he left an indelible legacy at Stanford, and that is why we are here today. Victor was a dazzling chair of medicine at Harvard and the Brigham from 1996 to 2004. In 2004, he moved to Duke as Chancellor for Health Affairs and President of the health system. After 10 outstanding years at Duke, again marked by enormous accomplishments, in 2014, he was elected President of the National Academy of Medicine. As an academic leader, Dr. Dzau has had an enormously positive impact on each institution with which he was associated. It's very difficult to summarize, even briefly, his many important scientific accomplishments. During his cardiology fellowship, he isolated and purified renin-specific antibody, and in this paper, published in Science, he and his colleagues took a large step in understanding the role of the renin-angiotensin system. In 1980, as a junior faculty member, he and his group at the Brigham were the first to show the enormous benefits of ACE inhibition in heart failure and subsequently in hypertension. He also pioneered the important concept of the tissue renin-angiotensin system, which has had a profound effect on cardiovascular pathophysiology. While he was chancellor at Duke, Victor and his team established the paracrine action of stem cells back in 2006, which has really moved the field of regenerative medicine to the search for and the isolation of the secreted factors. In his present role, Dr. Dzau has pushed the National Academy of Medicine into very important areas. One of these, of course, is the COVID pandemic, and in this article provides urgent lessons from COVID-19, while the world needs a standing, coordinating system and sustainable funding for global research and development. Under his leadership, the National Academy of Medicine plays an important role in combating climate change, and in an article published online just 3 weeks ago, he makes the case for a major expansion of the mission of academic health centers to extend beyond health, but to also contribute to the societal good. Most amazing, Dr. Dzau has maintained his active laboratory at Duke, where he spends each Friday and Saturday. And in a paper published just a few months ago, he and his team showed that using CRISPR-Cas9 mediated deletion of the angiotensin gene reduces hypertension, perhaps leading to control of human hypertension. So how can we describe this extraordinary man? Simply, he is a force of nature. Now, William Osler, widely considered to have been the leading physician of his time, bridged the 19th and the 20th century. He was a major figure in three outstanding universities: University of Pennsylvania, Johns Hopkins, and Oxford. Victor Dzau is a similar figure, bridging the 20th and the 21st centuries. He also has had a critical role in three great universities: Harvard, Stanford, and Duke. And what do they have in common? They are both graduates of McGill University. Well, now I would like to speak with you about the war against heart failure and really tell you my own involvement, which goes back for 70 years. These are my disclosures. I first became aware of heart failure in 1950 when, as a medical student at Bellevue Hospital, I had the opportunity to work in one of the first cardiac catheterization laboratories in the country. And the subject was heart failure. Now, what we had for the treatment of heart failure at that time was very primitive by today's standards. We had digitalis, which is used rarely today, and mercury diuretics, which were given by painful intramuscular injections and which were not very effective. Now, in 1960, the first thiazides were developed. I think chlorothiazide was the first one developed by Merck. And that drug made a big difference because for the first time you had an oral drug, an oral diuretic that people could take. And I consider the development of thiazides to be one of the really important milestones in the treatment of heart failure. In the late 1960s and early 70s, there were several new developments. Cardiac transplantation occurred in 1967, and loop diuretics, beginning with furosemide, began that year as well. In the middle 1970s, vasodilator treatment for heart failure became possible, and that certainly prolonged life. There had been very few instances of life prolongation before the vasodilator treatments. Now, 1980, ACE inhibitor. I showed you the slide of the paper that Dzau and colleagues published in the New England Journal of Medicine in 1980. This ushered in a major change in the management of heart failure. And I've also put a red circle around this because I think it is another milestone. And with the addition of ACE inhibitors, the prolongation of life, reduction of need for hospitalization was really put on the map. In the 1990s, there were two major advances. The beta blockers, which are very potent drugs for the treatment of heart failure, became widely used, and the angiotensin receptor blockers also were developed. In the year 2000, left ventricular assist devices came along, as did mineralocorticoid receptor antagonists. And 2 years later, implanted cardioverter defibrillators and cardiac resynchronization therapy became widely used. And if we look at the second decade of the century, we have the angiotensin receptor neprilysin inhibitor, or sacubitril/valsartan, the ARNI, and for most recently, the sodium glucose cotransporter 2 inhibitors, SGLT2. And I gave this a round circle as well because it is another milestone and an enormous one. I think people here at Stanford, Ken Mahaffey, has been very much closely involved in the development of one of the important SGLT2 inhibitors, canagliflozin. Now, the whole story of the SGLT2 inhibitors began with this paper published relatively recently in 2015. It came as a total surprise that empagliflozin, one of the SGLT2 inhibitors, in a trial called the EMPA-REG outcome trial, had an enormously positive effect. It reduced cardiovascular deaths by 38% and hospitalizations for heart failure by about the same amount, by 37%. Now, people didn't quite know what to do with this. I certainly was puzzled, and my colleagues in diabetology didn't expect to see this benefit. But to make a long story short, I think what has happened is this has been seen repeatedly. There have been multiple trials that have shown the benefit in patients first, in patients with diabetes and heart disease, then in patients with heart failure without diabetes. It's also been seen that diabetic renal disease is improved. So we have an important class of drugs. The fundamental mechanisms of these drugs is not completely clear, and it's still being debated. So on the top of the slide, you see potential direct myocardial effects of SGLT2 inhibitors. And they begin on the left with sodium-hydrogen exchanges, which are reduced, reduction of calcium, calmodulin, reduction of autophagy, and a reduction in inflammation. And at the bottom of the slide, you see potential indirect and systemic effects of SGLT2 inhibitors, and improved renal function, an increase in progenitor cells and increased activity of EPO, a reduction of sympathetic nervous system, and improved energetics. Now, how these work and how they intertwine is the subject of important research at the present time. Now, there have been 4 major paradigm shifts that have resulted from the SGLT2 inhibitors. The first one, SGLT2 inhibitors are not only glucosuric, but they also reduce the development and progression of heart failure and prolong life in patients with type 2 diabetes mellitus and reduced left ventricular ejection fraction, a major shift. The second one, SGLT2 inhibitors improve outcomes in patients with heart failure and reduced ejection fraction, irrespective of the presence or absence of type 2 diabetes. And thereby, they greatly expand the potential target population for these drugs. There are 4 major paradigm shifts. The third is that the SGLT2 inhibitors improve outcomes in heart failure with preserved ejection fraction and are beneficial in patients with chronic heart failure over a wide range of ejection fractions, expanding the target population even further. This is the first class of drugs that have been shown to benefit patients with HFpEF, and this is a major improvement in our care for patients with heart failure. And the fourth major paradigm shift is that these drugs slow the development of end-stage kidney disease in patients with diabetic kidney disease. Now, the benefit of SGLT2 inhibitors in patients without type 2 diabetes, but with a variety of chronic kidney diseases, appears to be promising. So I would conclude by saying that SGLT2 inhibitors are the statins of the 21st century. I have been quite fortunate to have witnessed and on several occasions participated in the war on the winning side. And the next challenge, of course, will be the prevention of heart failure. Thank you very much for your attention.
That was wonderful. Thank you, Dr. Braunwald. I want to turn it over to Dr. Harrington for a few comments.
So first off, thank you, Joe Wu, for the CVI sponsoring this annual Grand Rounds. It's a tremendous tribute to Dr. Dzau. And Victor, if you look behind me, I'm probably sitting at the same desk that you sat at many years ago, and haven't changed the furniture since I've been here. So it may be well. But it really is a privilege to have both you and Dr. Braunwald here, 2 people in cardiovascular medicine that I count as both colleagues, friends, and mentors. Having spent time with Victor in during my Duke days, and then having spent many years with Dr. Braunwald in the clinical trials arena, I feel quite fortunate to have interacted with the 2 of you. So thank you, Victor, for allowing us to have this lecture. Thank you, Dr. Braunwald, for giving this lecture. It's really a privilege to have the 2 of you here. And I look forward, Victor, to your annual visits in future years back to Stanford, where you did a lot of important work. Let me turn it over to Joe Wu to get our questions started. We'll monitor what's coming in through the Q&A. and try to answer as many as we can. So Joe, I'll turn it over to you.
So I guess, Errol, do you know if there are questions coming in? Actually, I can't see it on my screen.
Not yet, but we'd like to invite everybody to please click the Q&A button and answer questions for Dr. Braunwald. And while we're waiting for those to pop up, just want to say thank you to Dr. Braunwald for being with us. Again, thank you for that pre-recorded presentation. That was wonderful. And especially thank you for being with us today. No surprise, we have a good, robust viewership today. We want to welcome everybody who's joining us, not only within the Stanford community, but Dr. Harrington was telling me he was receiving messages from colleagues around the country. So welcome to everybody who's joining us throughout the country, wherever you are, to be with us today.
Well, Joe, if it's okay, maybe I'll ask Dr. Braunwald the first question. Gene, that was a fabulous look at 70 years, as you say, of tremendous progress. At the recent Heart Failure Society of America meetings, there was much debate as to perhaps the artificiality of distinguishing patients who have heart failure with preserved ejection fraction from those with reduced ejection fraction. And there's at least one camp emerging in the heart failure arena who have said, well, let's forget that differentiation. Let's just put everybody on foundational therapy, the ACE, ARBs, the MRAs, beta blockers, and now SGLT2 inhibitors. It's more important that we get patients on this foundational therapy than it is that we understand their ejection fraction. How do you react to that?
Well, pretty positively, Bob. Actually, it was, we described the first measurements of ejection fraction back in 1962 and published that in Circulation. We did not think it was going to be a very important measurement of cardiac function because it's so dependent on loading. So you can get the ejection fraction to be anything you want if you change preload and or afterload. And I think it has become too simple a way of classifying patients. So I am sympathetic to this idea. On the other hand, I would say that we do look at patients. We don't put everybody with heart failure into the same barrel. And there are a number of things. We obviously use biomarkers that tell us something. And we use clinical markers and imaging, and ejection fraction sort of is one of many ways of characterizing heart failure, but it is not the ultimate and most important way.
So we're starting to have questions coming in, and this question is also from Linda Barman and also David Marin. So Dr. Braunwald, what do you see as the most important method for prevention of heart failure?
Well, it's the prevention of heart disease. And I think that looking forward, I would say that we all know about secondary prevention, and we employ it constantly. Primary prevention in patients who have risk factors. But I think the future to really have an impact on preventing heart failure is primordial prevention. And that should begin very early in life, perhaps even in infancy with GWAS, and determining which individuals are going to be salt sensitive, whether they fall into a track that ultimately leads to hypertension, hypercholesterolemia. And I think that will take time, but I think that is the ultimate solution to the problem of heart failure.
Great. Another question from Jeff Sosserman. It is interesting how many cases you have described in which translational science preceded much of the basic science and vice versa. What are your thoughts on their relationship between basic science and translational science and the path forward?
Well, I think that they have to go hand in hand. I think that, if we want to develop a health system, I look on that as a chain. And the chain is just as strong as the weakest link. If we were to diminish the support of basic science, the chain would dissolve, it would break. And so we have to have each component. Means clinical medicine, it means population medicine, means epidemiology, but it also looks at the very basic aspects of biophysics and fundamental genetics. So all of these are important links in the chain. I think the interesting question was that sometimes we have a drug that's quite effective, but we really don't know why. And that's okay. That's okay. That'll happen sometimes, but we will discover why it's effective. And there are examples. I mean, look at penicillin. You consider penicillin. Nobody understood why it is bacteriotoxic. It took John Strominger about 30 years, for which he got the Lasker Award, to determine the mechanism of action of something as simple as penicillin. And then you also have aspirin, not known at all why it was helpful. And that doesn't mean we didn't use it, but I think we are using it more intelligently because we know its mechanism. So they have to go hand in hand.
I have a question for my good friend, Woody Myers. Woody has a question. What is the role of the public health system in this new era of cardiac prevention and treatment? What are the most important steps government might take?
Well, the most important steps that the government might take is to support research and to continue to support research. I think that I think it's very important to have a good academic industrial relation. But I think the core of the research should not be supported by the government. And I think that I think we're seeing examples of this with the COVID vaccines, where the government did a lot of the work and put in a lot of the money. And I think that the results, of course, are spectacular. So I think that is a key element.
Mm-hmm. There's a question for
Joe, can I make a quick comment? Just to remind everybody, please upvote questions you want to see answered. We have over 24 questions. We won't be able to get to all of them. So please upvote the ones you want answered most. And also please put any comments in the Q&A section if there are questions. Thanks, Joe.
Oh, thank you. There's a question from Anja Karlstadt. Wonderful talk, Dr. Braunwald. Can you please give us your perspective on the emergence of cardio-oncology and cardiovascular risk in cancer patients as well as survivors?
Well, let me just talk about cardio-oncology, which is a growing specialty. Now, it's growing because both cancer and heart disease tend to increase with age. So, and in many ways, this is the price of success. Let me give you two examples. You have a patient who has been a smoker, and let's say at the age of 55, this gentleman develops a massive anterior wall myocardial infarction. 15 years ago, he would have died. And now, using modern techniques, he has a good chance of survival. But he is now at high risk of cancer. Happens to be lung cancer because he hasn't stopped smoking. So now that wouldn't have happened so we have people like this growing up. We have an example, and a converse example would be a patient who has lymphoma, in Hodgkin's lymphoma in the chest. And that patient also, this would have been fatal a number of years ago, but because of mediastinal irradiation and modern chemotherapy, the patient is cured. This patient is cured. However, both mediastinal irradiation and chemotherapy damage the heart. So now we have a whole group of people who have escaped death, but have, because of the treatment, are at risk of getting the opposite disease. So therefore, we need cardio-oncology. It is a new specialty, relatively new specialty. It's been formulated. I think that there's a lot of, it's growing because there are more and more patients. And as the cancer field expands, most of these chemotherapeutic agents are cardiotoxic. And now a lot can be done about this. I think, first of all, you have to recognize who is at risk before you begin the therapy, and that may modify the way you give the therapy. Then during the therapy, you may have to change the dose or whatever. And then the cardiac consequences sometimes don't appear for a couple of years after the therapy is complete. So I think this is a very important subspecialty going forward.
Perfect. I think, as you know, one of your former trainees, Dr. Eugene Lewis, who's our chief of cardiology now at Stanford. Eugene has a significant interest in expanding the cardio-oncology service here at Stanford. So thank you for saying that. I have a question from Bob. Bob, go ahead.
Yeah, I'm looking through the questions on the screen, and I think this is a good question, Joe. It's come up multiple times that I could maybe get Gene, Victor, and you to all opine on. And that is, what's the role, or what do we see as the future role of regenerative medicine, cell therapy, for heart failure? An area that's had a lot of promise, a lot of hype, but a lot of disappointment. And maybe I'll start with you, Dr. Braunwald. Do you want to comment on the field of cell therapy, regenerative medicine? And then I'll go to Victor, then Joe.
Well, I'd like to hear what they have to say, because they're on the front line, and I'm just an observer. So let's hear what they have to say.
That was answered like a pro. Go ahead, Victor.
I would answer as a pro. I'd like to defer to Joe Wu first. It's called passing the buck down to the youngest person.
Yeah, I think, I guess to make it very brief, I think, Bob, as you know, as you alluded to in the past, that stem cell therapy, especially cardiac, has had some bad reputations, and mainly because in the past the science was not very accurate, not very precise. But I think, setting aside the previous controversies, I do think that the future is quite bright. And most of us think about stem cell therapy as taking the stem cells and injecting it back into the patient. In reality, once you have these stem cells, in our case, we generate patient-specific induced pluripotent stem cells that then differentiate into cardiomyocytes. once you have the patient's cardiomyocytes that are genetically the same as the patient, you can use these cardiomyocytes for precision medicine. You can use these cardiomyocytes for studying rare orphan diseases, patients with any type of dilated cardiomyopathy or genetic cardiomyopathy or Duchenne's muscular dystrophy. You can use these cardiomyocytes at a large population level, working with the industry for doing a population clinical trial at DISH. And then lastly, which is the one that you were asking, what happens about the cell therapy? As I mentioned in the past, there are some issues using the bone marrow cells, but I think moving forward, a lot of people in the field are trying to use iPSC, patient-specific derived cardiomyocytes, patient-specific derived brain cells for Parkinson's, patient-specific derived islet cells for diabetes and so forth. The major issue behind all of those cell therapy is cell death, cell death, cell death. And so if you think about cells as a drug, once we figure out the pharmacokinetics, pharmacodynamics of these cells and understand how do you prevent cell death, then I think there's going to be a big leap forward in terms of finally being able to replace the lost myocardium after myocardial infarction, which is otherwise not possible with any one of these conventional medications. And that's my answer here. But I think our speaker is Dr. Braunwald, not Dr. Wu. So I got to push the question.
Well, I will make.
Sorry.
I will make a comment.
Yeah.
Very general comment, because I'm not in the field. But I think two big mistakes were made. It went into the clinic too fast.
Mm-hmm.
In other words, people were so overly enthusiastic. It was too simple, and it didn't work. So that was one error. The second error was people gave up too rapidly. In other words, when it turned out that these things that weren't working, people lost interest in regenerative medicine. Not entirely, obviously. You have a very strong program, and I saw your paper, you and Victor's paper, and others in JAC just 2 weeks ago. So from a conference that you held, but the field has gotten much smaller because a lot of people turned away. So there were two mistakes: too fast to start, and too fast to drop it.
And then
Bob,
I think,
if I may comment, no, Gene, we're not giving up.
No.
This is really important. And the way I look at it is that, as you have said, it's a continuum. Actually, I remind you that in 1980, you and I wrote a paper called Cardiovascular Continuum, where we described the chain of events. And that's what you're saying. I think there's always room for regeneration because, let's face it, we're aging. And the aging, by definition, is a degenerative process whereby we lose cells, and whether you do it through major events or minor events, but we can replace them. So regeneration is going to be a really important area in the future. And it doesn't have to be cell-based, as many many of us are working on molecular base of regeneration. And so then you can take a pill and it can work. So I am very bullish about this area. But if I may make a comment, Gene, I want to say to you personally, thank you for giving this lecture and how much you mean to me in my entire life, personally and career. And I hope you caught my comments earlier. But I would say things I've learned along the way from you, from Bob, from Joe, from others, are the fact that, number one, as we said, that mechanism of action. I think frequently we don't know how drugs work, and we have a reductionist approach, reductionist. For example, an ACE inhibitor, we know that it worked way more than inhibiting production of angiotensin II. In statins, we know way more than prevention of cholesterol metabolism. And therefore, I think in the SGLT2, I think there's a lot more things we haven't learned. And the days of reductionist research is probably too simplistic in thinking about this. Now, that being said, it's great to make that observation based on the hypothesis, and then seeing that it's done so much more that opens up research for so many different areas. So I think this is just outstanding, the kind of things I learned from you in the journey of 70 years in heart failure. I think my final comment is what you said. At the end of the day, the earlier prevention is better. So as we think about even healthy longevity, we think back on how it's not just about people of age. It's about people that we can begin to intervene and make the right kind of biologic interventions very early in life, whereby as you age, in fact, you continue to be healthy. I saw your point about early treatment. How early is early? Well, you've demonstrated in the ACE inhibitor area how early can we actually give ACE inhibitor after myocardial injury before your heart failure. So I think this, to me, is an entire journey of continuum. And we're just learning so much more, as you said, based on basic research and clinical translation. Thank you for paving the way. I certainly remember the days where you were right at the bench looking at infarct size, reperfusion, and look where we are today. And when we think about so few people or fewer people are dying from acute myocardial infarction and now in heart failure improvement, you've done a lot for the field and I'm forever grateful.
Thank you. Thank you, Victor, for this most uplifting message. And I agree with you completely. And just a short commentary for me. I think some of you may know Stanford is starting the first human trial in the US, injecting human ESL-derived cardiomyocytes into patients. And that's really after 15 years of hard work trying to understand how these cells behave. And so for any scientific discoveries, I do think it's a long journey. And I think the main message is for the young scientists who are listening is, if you have a mission, if you have an idea, if you have a goal, don't give up and keep going as long as the idea makes sense. And so on that note, again, thank you so much, Dr. Braunwald, for giving this most wonderful talk and to kick off this Dr. Victor Dzau Distinguished Cardiovascular Medicine Lecture. For the audience here, we will have this annual lecture every year, and we are honored to have all of you participate to celebrate the legacy of Dr. Dzau. And if you do have any suggestions of who the next speaker will be for next year, please do let Bob and I know. Thank you so much, Victor, and thank you so much, Dr. Braunwald.